right. Welcome to this final live case session. My name is Fahim Jafary. I'm an interventional cardiologist in Singapore. My co-chairman is Dr. Paul Kao from Hong Kong, and we have Taiwan. Sorry, my bad. And we have an outstanding panel. So I guess we're going to go to Asan Medical Center for the first case. Dr. Kang, Fahim Jafary, and Paul Kao here. Can you hear us?
Yes, I can hear you very well.
Super. Well, thank you for the case, and tell us about your case, please.
Yes. I'm Dr. Do-Yoon and our senior fellows Kyung-Won-So and Sung Park, and our senior technician Jin Sung-Mo will join this procedure. Can you please briefly talk about the case?
Yes. Thank you for the introduction. The case is the patient is a 71-year-old male who was admitted for the evaluation for the effort chest pain and CT abnormality. He had history of multiple events of stroke and ASD device closure. He had hypertension, diabetes, and hyperlipidemia. He had been managed for stable angina. The EKG showed normal sinus rhythm, and chest X-ray showed no cardiomegaly or pulmonary edema. The normal echocardiography was normal. The coronary angiogram showed distal RCA significant stenosis, and caudal view showed diffuse circumflex artery stenosis.
Yes, minus please.
And the left angiogram showed severe calcified lesion from distal main to Proctor AD, which shows consistent of bifurcation disease.
Yeah, the patient is with stable angina, and the RCA disease is intermediate and FFR negative. I do not want to treat the diffuse RCA disease. It's not severe. The problem is the left main, and these are circumflex diffuse calcified lesion. Can you please show us? This angio shows the very severe calcification of the left main to the Proctor AD. And also you can, next please, next. Also you can see that ostial left main is diseased. And you can see very heavy calcified coronary tree. And minus. And this is our case. Can you please do some recommendation for this
So
patient?
clearly very complicated. Heavily calcific. The ejection fraction is normal, right?
Yes, normal.
Okay. So, Paul, how would you do this? Would you do this with mechanical support, or?
Well, obviously, this is a left main plus triple vessel, and all are diffuse, heavily calcified. So back in Taiwan, first thing is that we will have to get our surgeon to have a meeting with the patient and the family to have a shared decision making, because obviously surgery is not a bad idea. But I believe the case had been already selected for the live case, so I think that part we don't have to discuss. The thing is that about the distal diffuse calcified circumflex and also the left main, like mentioned by Dr. Kang. So I think these two parts we need to image so that we can have a better plan.
I mean, given the extent of calcium, my thoughts would be that you're going to have to ablate this, given how extensive the calcium is. I mean, there's thick calcium, it's on both sides of the vessel wall. So I don't know, anybody in the panel would have a different view on this? Would you ablate, or would you IVUS and then decide?
I will do IVUS and then decide. If IVUS cannot pass or pass with difficulty, then I will go with voltabation.
Yeah.
The IVUS, the main objective of this is to see the ostial surge. If the ostial surge is okay or distal left main is okay, then maybe just standard course, because the surge is really heavily calcified.
I think you have your answer there. I was stopped over there, right?
And that's LAD.
That's right.
Yeah, yeah. So I mean, honestly,
tried, but I
Lam,
was
for
stuck.
me, I would just open up an ablation device of my choice when I see that kind of
I
calcium.
just want to briefly share the IVUS image. Can you please? This is the point where the wheels talk. IVUS, that shows the very severe calcification. And
Then
left main, proximal, it's relatively okay. So distal left main is very severely calcified. And so I decided to do the ablate the lesion with rotational atherectomy.
And in this sort of scenario, usually if you do rotabation to LED first, that will be more safe before you do rotabation to the circumflex.
RPM.
Because in this scenario, most of the time the osteocyte is also heavily calcified.
So, Dr. Kang, is it rotablation or orbital for you, or it doesn't matter?
Okay.
In case if your IVUS cannot pass, most of the time the best choice is still rotabation.
조금만 더.
Yeah, I agree.
Okay.
How about
so
the
we-
left main ostium, the lesion, the morphology? I mean, is it calcified or how many stenosis on the patients?
Oh, yeah, that's very interesting point. Actually, I thought that there would be some disease in the left main ostium, but IVUS, can you please show the IVUS of the left main ostium?
Yeah, from the IVUS, left main
not
ostium
very
doesn't
much
look that,
disease, yeah.
not that diseased.
Yeah.
I think most of the
but I think
calcium is
that we
where that
should-
IVUS
I should
stops.
care.
So Do-Yoon, how about the IVUS to the circumflex?
I did not try it.
I think the IVUS was stuck
actually-
already in the LAD, so it's
Yes. The caudal view 한번 보시겠어요? Can
because
you
of-
please show the caudal view?
Because there's some
Actually, the circumflex is very severe, very calcified, very long, and we all know that this is the one of the most difficult lesion we can treat. But the circumflex is not so dominant, and it's distal disease. 뒤에 열어야 될 것 같은데. So
Actually, I just
I'm
want to know
thinking about the
the
medical treatment for that.
just want to know the ostium of the circumflex.
Oh yeah. Later I will try. In the IVUS, the ostium is not evaluated. We could not pass left main. So I will try to open the left main and then I will re-evaluate it.
To be very honest, given how much calcium there is in the distal left main and given the size of the distal left main, which is a relatively bigger lumen, I might be inclined to take orbital just because you can ablate the main also. Obviously, the alternative is to take a bigger burr or two separate burrs, which, in order to ablate the left main as well as the LAD.
That's right. This is 1.5 or,
Okay.
and I will begin. So tabulate it. Here is the point. Yeah, there's strong resistance. The patient vital sign is okay. Heart rate is 60. And still resistance.
What speed are you ablating at?
I will stop.
What's your
It's 180.
180?
180.
So Dr. Kang, this is Euihong from Cochrane Memorial Hospital. So what
Yeah,
kind of
yeah.
wire do you use? It's a floppy wire or regarding the wire
Oh,
bias?
it's ES wire, extra support.
Extra support, that's good.
Yes. And also the patient has distal disease, very severe, tight distal disease. So I think taking care of to not to make damage at the distal vessel. Once again.
From the panel, can I have a show of hands? How many would go with a rota floppy? Would start with a rota floppy? And how many would go with extra support? Oh, really? The extra support?
No, I'll go for a floppy.
Yeah, I usually start with a floppy and then see what else I need to do.
What would be the difference between using the floppy versus extra support? Does it affect the outcome of the rotablation or for the safety?
I think that my opinion to use extra support in this case is that the angle between the left main to the LED is a little bit steep, and considering the wire bias and calcification distribution is also opposite side of the carlina, so maybe extra floppy wire, extra support wire can get enough the wire bias in this case.
Yeah. Now we passed the region. The rotator passed the region without any resistance now. So I will stop the rotabulation and we'll evaluate the intravascular imaging with IVUS again. 나가볼까요? 준비해 주시고.
How much down do you get during the rotabulation?
I tried it for the 4 cycle. Yeah. Okay. 와이어 조금만 더 넣어주시고. Yeah.
Well,
Keep the wire, please.
I think a lot of discussions has been on the wire bias using a rotablation.
Yeah.
But in this particular case, because the IVUS cannot be passed, so you don't know actually what is the wire bias.
Yeah,
And the vessel size is very big. For this case, wire bias, if you use 1.5 bar, is not important. Your aim is just to cause it.
Exactly. That's why I think to start with the rotafloppy is safer. You don't have to think about the bias. Because after that, then you can evaluate. If the bias is unfavorable, you can change to the extra support.
But sometimes the extra support wire can dig into the vessel wall in the wrong direction, and you could end up with a perforation.
Thank you. Yeah,
The distal flow has gone down. Looks like there's something going on in the distal LAD.
Yeah, there was some very severe disease, and I think that is blocked with the wire related the
Yeah, there was a distal lesion. You're right. Yeah.
And we also need some vasodilator. 라이트 한번 주세요. And let me check the IVUS. With waiting for the distal LAD recover again. And patient doesn't have symptom now, and EKG is normal without ST elevation or depression. Let's check the proximal. I want to more concentrate on the proximal now. Still there's some resistance, but it passed. It's very diffuse disease. Here is the mid LAD, the septum, and diagonal branch. Pull back. I pull back with a 1 millimeter stack.
So nice landing zone distally, which is good.
Yeah, but it looks a little bit long with the long stand. Still here is very severe calcification, but not concentric, but the thickness is quite big. And here also you can see surrounding calcium. It's the big diagonal branch. Diagonal branch opening looks good, not diseased. And here is the opening of the left main LAD. And circumflex ostium looks very well.
Right.
Yeah. And this is the left main ostium. Yeah. Can you please review the IVUS? Yeah, that would be the point that with the most severe calcification.
Actually, the very distal left main is also very diseased.
Yes. Left main 보여주실래요? 더 뒤에. 오케이. 조금 더 뒤에. 거기부터. Yeah, this is the ostium and left main.
So you're seeing some rotablation effect with some reverberations, but obviously you need to modify the calcium more.
Yeah. What do you recommend for that? Larger size ball or NC or IVL? What would be the best option for this patient?
What does the panel think?
I think the concentric calcium is very short. You already have reverberation. So I will go for maybe a cutting or NC instead of IVL.
I have a slightly different view on that. I mean, I think the vessel is big. I might want to go with a bigger burr because there's a lot of calcium. But I take your point. You know, you can try a balloon and see what happens.
Yeah, I agree with the Carl's opinion. Even when I use the 1.75, I think that there will not be very big benefit from the increase in the ball size 0.25. So I will continue the procedure with the NC, with the opium balloon with a very high pressure.
Will you consider to IFAS the osteoset?
Actually, I'm not so much thinking about it because the wiring into the circumflex itself is very difficult, will be very difficult, and it can make some damage to the circumflex. And the angio and the IVUS shows the clear opening of the circumflex. So now, at this timing, I want more concentrate on the opening the left main distal and the LAD osteum.
Will you consider to use spider view to check the osteocircumflex if you don't do the IFAS?
Let's see. Okay, test two. Okay, thank you.
You ready?
That's good. That's
I
good.
believe that, it'll be okay.
In this scenario, if I do not have any plan to touch the circumflex, I may consider to use bigger burr for the AED. Try to remove the calcium as much as possible. But of course, for this case, I guess you can also test with NC balloon first.
Yeah.
Yeah, I mean, I agree with Lam. I mean, but there are different ways of doing things. I don't think there's an absolute right or wrong.
Yeah.
Paul's point is very valid too. That just get on with ballooning and get it done with. But I agree. I would ablate a bit more, because that's a lot of calcium there.
So your next burst size will be a 2.0 or 2.5?
Either a 2.0 or a 1.75. Yeah. And why 1.75 and why not 2? Who the hell knows? It's anybody's guess. But that's one of the reasons why I thought orbital might have an advantage in this particular case.
This patient is now on the radial 7 French, and is it available to use 2.0 or 2.5?
So, Dr. Kang, while you're working, we are going to go over to the other lab at Asan Medical Center, and we'll come back to you. Thank you.
Thank you.
So can we go to the other lab at Asan Medical Center?
Just have it.
Hello. Can you hear me?
Yeah, Dr. Ahn. We can hear you and we can see you. Yeah, please explain your case. Yeah.
Okay, I'd like to introduce my teams, the Hyeon team, Hsien-Li Ahn. The Hyeon team introduced our case. Could you?
Thank you for the introduction. I would like to present today's case. 62 years old male presented to our clinic with chest pain. He had no previous history of medical history. He was diagnosed with unstable angina. The ECG showed T inversion at precordial read. Chest X-ray revealed no pulmonary edema or cardiomegaly. The echocardiography demonstrated preserved LV systolic function without definite regional wall motion abnormality. Here is the baseline coronary angiogram. The RCA showed only mild disease. However, the entrance of the left circumflex artery was severely narrowed, and the high ostium of high OM was also affected. Additionally, proximal RAD showed total occlusion with the collateral flow coming from RCA, and the distal left main demonstrated subtotal occlusion. Today, our plan is to treat codification regions involving left main, left circumflex artery, proximal RAD, and RI. Thank you.
So could you show us initial angiogram? This is RCA. So good collateral from the RCA to the LAD. Next. Next, please. So there is some rupture, the left main, and very tight. You can see the very tight stenosis.
Right.
This is circumflex and small OM and RI, LAD.
Yeah.
Next, please. This wider view. So left main quadriplication. So the matter is that the LAD wiring. Definitely CABG case, but if we can if we successfully wire to the LAD, I think the left main bifurcation stenting would be comparable to the bypass surgery. Fortunately, patient RCA supplied the LAD collateral, and if you look at the epicranial view Won-Jang, so Won-Jang, please.
Epicranial.
Yeah, ready? So you can see the ipsilateral collateral. So the angiographically very tight left main trifurcation disease, but physiologically this is a protected left main. Actually, for this patient, I do believe that the angina is not due to the subtotal occlusion of LAD, but associated with the big RI branch tight stenosis. But even though I'd like to insert the wire to the LAD, and then let's see.
Because from here it looks like there's a connecting microchannel.
Yeah.
Into the LAD.
Test.
So, Jung-Min, Fahim, Jafary here. What wire are you using? Tell us what your wiring strategy is.
This is XT wire.
Okay.
It's amazing, the last session of the event, but then you picked up so difficult cases, very complex ones.
Frankly speaking, this patient come to my office the day before yesterday.
Oh, okay.
But that's even more amazing that the guy is walking around with this.
Yeah.
The spider view showed a very sharp angulation into the LAD. So I'm wondering if that might be the view to...
Yesterday's was Thanksgiving.
How about LV ejection fraction, and do you consider mechanical support for this case?
Ejection fraction is normal.
And it's protected. So I wouldn't use mechanical support.
Will you consider to use RAO caudal view to try?
I think he wired.
Already wired.
Very nice, beautiful.
Test,
beautiful.
please.
Beautiful, very nice.
Yeah, that's right.
Could you give me the conventional wire, please?
Now you are left with the left main trifurcation. So, tell us briefly what are you going to do?
Yeah.
You want to do?
So we saw the IVUS to the left main to the RI branch. Could you show us the IVUS? My concern is circumflex ostium. Could you run, please? This
the,
is
the circumflex looked tight on the angiogram, so.
But this is very interesting. Circumflex coming from the 6 o'clock, relatively open,
Yeah, open.
and then very tight. So
Yeah.
initially I thought the double crochet something, but I changed my mind after the IVUS findings. I like to do some often two-stand
Yeah.
technique crochet through the OM and LAD.
Okay.
So far, patient didn't complain don't complain in chest pain. So that's why this is actually the protected left main.
So basically, you want to keep the circumflex open, but not necessarily stand it.
Yeah.
It's the intermediate and LAD that you are after, right?
Yeah. Okay, ready?
Ready?
So then we will go to the third lab in a second.
Okay. 통증이 심해져요. Column, please. Ready?
Ready?
Okay, slow flow. 주세요. 네, 조금만 계세요.
And Dr. Ahn, during your IVUS run,
Yeah?
did you pay attention to that ulcer in the left main?
No.
Because from the
Also,
angio,
there is some ulcer. Yeah,
Yeah.
there is some ulcers. Could you show us the ulceration of left main? This is left main. Can you see the IVUS findings? Yeah, here is just some observation of left main.
Yeah.
10. Deflation. One more. 10. Deflation. Yeah. After insert a wire to the LAD, patient complained chest pain, but blood pressure is so far very stable. Definition-wise, this is very high-risk coronary intervention, so 10. Many want to insert some hemodynamic support, but I think the deflation, the hemodynamic is very important during the procedure. If we insert the wire, hemodynamic is very stable, or ballooning hemodynamic is stable, then we don't need to insert hemodynamic support. Ready?
Ready?
Absolutely agree.
Okay.
Usually in this sort of case, we just establish RASA access to prepare the injection of MCS. But usually, if the EF is normal, usually we won't put it on MCS.
actually you can calculate the chip score. I think this patient, the chip score is actually very low. Because the LV function is normal. There is no need for rotablation.
Yeah.
No bilateral approach needed.
Ready?
Ready?
So I think the chip score is going to
I
be
agree.
low.
We would just. do
Would you
this.
put a wire in the circumflex though, just for protection?
Okay.
Recently, I heard about a concept for those bifurcation because many
So
negative remodeling, some angulation, sometimes some
Could you give me
patients,
the-
some operators suggest
stand.
P kissing.
So
I mean kissing in over here. Do you think this will help?
23.
P kissing and then
LAD.
change the anatomy.
아니 LED 3.5 high pressure.
So, Jung-Min, while you're working, we're going to go back to Dr. Kang's lab and
Okay.
just take a look, and then we'll
Okay.
come back to you. All right?
Okay.
We'll let you work in
Okay.
peace. So, can we go to
ready.
Dr. Kang?
Yeah.
Dr.
Hi
Kang, we're
again.
back.
I'm just putting the stand. Yeah.
Okay.
Deflation.
Tell us what you've done.
I did applied super NC balloon. Yeah, for 3.0 up to 34 ATM at the from the mid and the proximal LAD.
34
And
atmospheres.
34 ATM. But still there is some the heavy calcium does not expand very well. So I applied it again and again and again. And then implanted 2.75 and 3.5 stent because the length was long and there was size discrepancy. I implanted 2 separate stent. And let's see. It's just a stent result. I did not apply the NC again. This is the distal edge. Yeah, just distal to the septum branch. And the septal branch is coming. And here you can see also the 180-degree calcium that does not expand very well. So we need more aggressive post-dilation for this region. And here's the proximal. Here is the opening of the LAD and distal left main.
Looks nice.
You can see still there is some
here.
the
Little under,
limitation here.
yeah.
Okay.
Yeah, because I did not apply the big NC balloon yet, so I will further dilate it with a bigger balloon.
Usually in this situation in our center, we will do IVL. Despite the stent was put in, but we still put IVL.
IVL, yeah. Actually, I also considered it, and always using the IVL, the problem is the cost.
Well, Dr. Lam, if you already decided to use
메인부터 할게요.
IVL,
메인
should
4.0
we
해도 돼요?
actually use it before stenting, right?
Yeah,
Proctor
usually I will use before. But from the IFAS, you can see the calcium, there's a C shape. It creates already a tunnel.
Yeah.
Sometimes you use NC, the force is not very effective. But with a tunnel, if you use IVL, the force will be more effective.
So, Dr. Kang, what are your plans for the circumflex?
Actually, I want to just medically treat the
Okay.
circumflex.
Okay.
That was my original plan.
Okay. So you're going to optimize now with high pressure balloon dilation and then
Yes.
treat the circumflex
This is
medically.
4.04. Yeah, that's right. That's my plan. And I think that the opening the circumflex would be another very big burden and very risky procedure. Yeah.
Tell us which balloon are you
Penny?
using now?
This is 4.0 by 15 NC balloon. Yeah, 24. I want to optimize the left main ostium first deflation because there was some protrusion into the free lumen. So I do not want to make the damage to the ostium by the catheter. So I opened it first.
Also,
And
this
because
will minimize.
This is 4.0.
This will also minimize the unintentional stent lengthening.
That's right. That's what I hope.
There's a fourth.
And because this is very bulky balloon, bulky strong NC, I will just open the left main with this nominal. 18.
18.
So this is a regular NC, not a OPN or
Regular NC.
Okay.
Regular NC, but it opens up to 28 very safely and deflation.
So, Dr. Kang, we got to move to the next room. So, can you show us an angiogram?
Oh, yes.
And
Okay.
I think then we'll let you work in peace.
Yeah. Still, there is some lumen limitation where I need more
Yes.
optimization.
Yes.
Can you show us the caudal view, what the circumflex looks
yeah.
like? Yeah. So I think back to the same point, whether you ablate more or you use IVL, some additional modification is needed. Yeah, the circumflex looks okay at the ostium. Okay.
Yes, and also the distal left main, there's some eccentric calcification, and in this view I cannot see that. So that's why we should check the multiple views.
Okay. Super. We'll let you work in peace. Thank you so much. This is an outstanding demonstration. And we will move back to Dr. Jung-Min Ahn's lab now.
Yeah, thank you.
Thank you.
3.5죠.
Jung-Min, we're back to you.
Okay, just a moment. Then I will explain what we did. 12. Deflation. Okay, I implanted the stent to the left main to the OM branch, and just I crushed the OM branch stent. I cross over the circumflex ostium. Ready? I hope circumflex flow will be okay. Ready?
Ready.
Okay. So could you give me the stent? 35.
So, sorry, Jung-Min, this is a stent from the ramus across the circumflex?
Yes, right.
And you...
So based on the IBUS finding, could you show us the IBUS of the circumflex? This is a pullback from for the ramus to the left main.
So it's tight, yeah.
Okay. This is the ramus, and here is the OM, another OM. This is circumflex. So circumflex opening looks not tight. So I just crossed over from the left main to the ramus, being ramus. This is after the crossover and after crush. So circumflex ostium looks fine, flow is good. So I don't care ramus and circumflex anymore. So I just focus on the left main to LAD.
So you crush the ramus stent from the LAD. So now that circumflex ostium, you have 2 layers of stent.
Yeah.
No, one layer actually.
No? Because the stent is...
cross.
So the crushed stent is actually facing the circumflex ostium.
Yes,
and then you are doing another stent from LAD to left main. So the circumflex will actually behind 3 layers of stent.
Ready?
Ready?
Test.
And what balloon did you use to crush the stent? Because the left main is huge.
35.
35.
Yeah, because this left main is not that huge, so 35.
I think I agree with Jung-Min that the circumflex ostium looks fine. But after 3 layers of stent, I'm not that sure. So we have to make sure at the end of the...
One alternative approach would be to, do it conventionally, put your stent in the circumflex, DCB the ramus, and then, do a DK crush or a mini crush across the circumflex. Somehow that seems more physiologic, anatomically seems more, in line with things.
10.
There's no randomized data, I think.
You can't have cases like this to randomize.
Yeah.
Not enough.
Absolutely not,
So let's see the flow of circumflex. Ready?
Ready.
Okay. Here is the spider view. Ready?
Nice.
Excellent result. You make the complex thing simple.
Yeah, it's beautiful. We're going to see if we can go across to Dr. S.J. Park's lab and let you work in peace. But I'm going to guess you're going to you're going to part, and then you're going to do a kiss and then IVUS.
Yes, actually, I will see the IVUS first.
Okay. All right. Well,
선생님 지금은 가슴 멀쩡하시죠? IVUS.
Okay, we'll look at the IVUS and then go across. So show us the IVUS. Yeah.
Okay. So this is the distal landing. Distal landing is very nice. Distal stand lands on the very mild plaque. Vessel size is more than 3.5, almost 4.0.
Yeah.
LAD, Proctor LAD, very huge vessel. To consider the some safety concern, I selected 3.5, but definitely we need 4.0 or 4.5.
Yes.
Oh, but this, huge vessel.
Yeah. It's a bit malapose.
Stem location is very nice, but definitely we need 4.0 or 4.5 something.
Yeah. Well, thank you very much. That's an awesome. I mean, you made a really horribly complex case look like child's play. So, hats off to your skills. So, thank you very much. Congratulations. So, can we move on across to Dr. S.J. Park's lab? Dr. Park, can you hear us? Hi, Fahim Jafary here, Paul Cow here. Tell us about your case.
Okay, thank you. It's really thank you for joining us up to this long day, late evenings. I'm very happy to have that our legend, right? Antonio Colombo is a really old friend. Is getting together. I'm very happy and honored. And Dr. Kim Joo-hyun is our junior colleague's new family, and maybe he will growing. Dr. Wee, Dr. Iman from Bahrain is our fellowship. And so, all right, we're gonna prepare last cases. And so, Iman, you presented the case first.
Yeah, thank you, Professor, for the introduction and the honor. Our patient is a 62-year-old gentleman. He was referred to Asan Medical Center for a history of exertional chest pain. Next. His past medical history is positive for diabetes, hypertension, and dyslipidemia. His clinical presentation has been diagnosed as stable angina, functional class 2. Next. His ECG shows normal sinus rhythm at a heart rate of 70 beats per minute with no acute ischemic changes. Next. Chest X-ray is unremarkable with normal cardiothoracic ratio and no signs of pulmonary congestion. Next. His echocardiography showed normal systolic function with no regional motion abnormalities. His CTCA showed a calcium score above 2000. Next. His baseline coronary angiogram shows non-dominant RCA. On the left system, we see that the mid and distal portion of the LAD is normal. Next. On the caudal views, however, we see that the proximal LAD is severely diseased, especially at the ostium and calcific. So next. Our plan for today is to tackle that proximal LAD lesion, IVUS guided, and to discuss about calcium modification techniques that we'll go ahead with.
Right. This is visually angiographical is not too much complicated, right? So anyway, very big vessel, prox LAD, short lesion length, relatively big vessels. However, we can expect some calcium, fluoroscopic calcification for that. And so, anyway, Antonio suggests a lot of, kind of wave of treatment for that. And so, discuss first, how would you do that first? And then, Antonio, you
Okay, so definitely if we go to place a stent, we try to be precise at the ostium of the LAD. The left main is super short, it is huge. We will not anchoring the stent in the left main, which will give too much distortion. And we will go right distal to the diagonal. The problem here is calcified, but doesn't look tremendous. But we did the IVUS, we pre-dilated with the 2O, the diagonal, and we did with the LAD, and we did IVUS. And the IVUS confirmed that there is calcium, but there is some reverberation. So most probably high pressure balloon will be sufficient. But I was telling Dr. Park that if this case had severe calcium and you have to do rotablation, rotablation by itself would not be sufficient because the vessel is 4 millimeter. So the other alternative is to do IVL after rotablation. But if you have some economical concerns and you cannot do IVL, you can take a 2-O balloon, go into the diagonal, inflate the balloon at 4 atmospheres, not too high, and do rotational atherectomy toward the LAD with the balloon inflated. The balloon will push the burr and will make like a directional rotablation procedure. We tried in vitro, if you inflate the balloon at low pressure, non-compliant balloon will not break. If you inflate it at 7, 8, it may break. But if you keep low pressure, the balloon is elastic and the rotablation. But in this case, we don't need. I think will be an overdue. So we did a 3.5 non-compliant, high pressure 20. Then we did IVUS was okay. We did the cutting balloon at 12 atmosphere, 4 millimeter, and it's better. It's still eccentric because the calcium is very nodular and very eccentric, but there's not much we can do.
Right.
Okay, that's my talk.
Really, I'm very excited to hear the new strategy in terms of balloon inflation, 2 millimeter balloon, and rotablation for the big artery calcified regions is really. So I want to try that. However, this is
but here in this case is not needed.
All right.
We could, honestly. With lithotripsy, this procedure is less important. But
so
if you have economical concerns, maybe an issue.
As just suggested, Antonio, we want to do just NC balloon first. Okay, before that, the IVUS findings we have already done, and LED IVUS and download IVUS those. Okay, would you?
Yeah, let's show the IVUS.
All right. IVUS, LED.
So this is a baseline.
Very eccentric, calcium on the carina side, circumflex area. And then, would you show us diagonal branches? Not so
this is a diagonal.
Yes, it's a relatively big one, 2.5.
3 millimeter almost.
If you look at the osteal
not
part,
much disease.
Not too much disease,
no.
Right? All right. So.
And the calcium is on the opposite side.
Yes.
Yeah, it is. So anyway, as suggest as Antonio, we want to do the C5 and C volume first. Okay, would you show us that one?
We did a 3.5,
NC balloon.
20 atmosphere. So you see that the balloon is inflated asymmetric. You see how the wire get pushed on the left side of the screen where there is calcium. The only wall that expands is the opposite, the one near the diagonal, because there is no calcium there. So,
all right, after the NC balloon 35, still the
result is so and so.
Not enough.
Not acceptable.
Right, minimal standing cross-sectional area. And so we want to do, okay, IVUS again, shortly, and then you want to move.
SJ and Antonio, if you want to choose between NC and cutting, which one you should go first? Now you did balloon first.
I go first most of the time with the NC because it's cheaper. But I have low threshold to go to cutting. Of course, if I use cutting, I like to inflate the cutting at 20 atmospheres, but downsize at least half a millimeter because It's first of all, it's some compliance, and I don't want to have any rupture.
Exactly as Antonio expected, the 35 NC balloon is not enough.
No.
We cannot
No.
enough, right?
So we use a cutting balloon 4,
Yeah, so, all right. This is cutting.
cutting, inflated at 12.
4O balloon.
Yeah, maybe I would have gone maybe 18, but it's okay.
And the second
So
time?
you still see that the wire is
Still
pushed
away,
on the left
All
side. No much is happening for the calcium.
Second time inflation of a cutting balloon is up to the almost 15,
Yeah.
18 atmosphere
Yes.
high pressure. As the indentation is disappeared, then
Yeah.
maybe you're going to expect
Yeah.
a little bit bigger, cross-sectional area. All right. Then, what do you think?
So angiographically looks better. It's still it's very
All right.
difficult to get a good angiographic
All right.
result with this eccentric calcium.
So, Ibis again, right?
Is there a bit of Corona
Yeah.
shift in the circumflex? or-
Yes,
Yes,
yes.
exactly, right?
Yes,
So-
and this, after stenting, unfortunately, this carina shift will be more
Will get
pronounced.
worse, yeah.
Yeah.
After the cutting, a little bit, getting better. Would you show us again to Oscar part?
Can you stop where there is the
All right, here
small
we are.
lumen?
Here,
No, here, no, a little bit.
already.
A little bit more. Very focal, super focal. Maybe here,
All right.
here. Stop, stop, stop. No, no.
Approximately. Okay.
So
I think
we
it's getting
measure,
there, right?
we measure the cross-sectional area. You can measure the area.
All right. So,
The area.
Do-
It's
Dr.
not
Colombo,
bad,
are you
it's-
thinking DCB by any chance?
No, no. Here today I've been forbidden to. I can only think but not do.
stand.
I can only think but not do. But
right.
if I was thinking DCB,
Stand.
the reason why thinking DCB is to minimize carina shift and to minimize compromise of the diagonal. But I would do more lesion preparation because I'm not. It's not easy here
But
with the
real
eccentric calcium
jokes
to
aside,
get a good result.
I think jokes aside, DCB isn't such an off-the-wall thought.
No,
I mean,
no,
if
it's
you get a
not a
good
bad
result and
idea.
you can DCB it, why not?
Yeah, it's not. I agree with you. But we have 20 years of tradition on our back which tells exactly the opposite. So we have to move slowly, but we will get there.
Just first.
So this is a stent.
Just, yeah.
So
Just,
this is a 4 12 millimeter
12.
stent.
just okay.
So,
And,
Dr.
Dr.
Park, tell us how you're
Park,
positioning
yeah.
the stent.
SJ, how do you precisely
Yeah.
position that stent?
Yes, precisely. I want to just precisely deploy the 4O 12 millimeter. Okay, take a picture here. So one more, so full injection. What do you think?
Maybe a little bit
Come
more
back.
back, just.
Which stent is
just
this?
a little bit.
Test
It's
the,
a science.
Zions, okay.
you want to pull it out.
So Zions
in
has the
the science
advantage.
stent,
Mostly the stent edge is on the balloon marker.
Stent is on the marker, yeah.
yeah. So the marker will tell you exactly the end of
Just
the
a-
beginning of the stent. I think looks pretty okay.
Okay, tester.
I think looks okay.
Inflate. We
Inflate.
don't need any more
Inflate.
hesitations. All right. Nominal. 16.
So it opened up very nicely,
All
so
right.
that's good.
Inflate. All right. This is 1 minute. Okay. Take a picture first and then full shot. All right. There are some, corona
You see,
shape.
Corona
you
shifting,
see
yeah.
that the carina shift got maximized.
All
FFR,
right. Anyway, you're
SJ
gonna optimize it. What do you think is circumflex ostium part? What do you wanna do some?
I think, I will do some dilatation, just cosmetic, because I don't like. If I send these to the referring cardiologist, he will get upset. So I do some 3.5 gentle kissing, just to be a little bit. I know that is not scientific, but sometimes the eye needs to be satisfied.
So, what?
I
All
don't
right,
you know-
we have not enough time. However, if I do FFR for that,
FFI is going to be negative.
you wanna
FFI is
do
going to be negative. You know.
If FFR is negative, you want to do why? Is the morphologist correction?
Because it's very difficult to convince other people. They will get upset. They will tell you that you left a critical stenosis.
All right, Dr. Kao?
I think it's a social decision, not a
All
scientific.
right, great. What about the,
I will
Dr. Kao
take
and
the wire from. I think you can do IVUS now.
From the panel?
Make IVUS, make sure
Yeah,
that
why
the
not?
stent
wanna
is
do-
well expanded.
If you want to do ours, and then you
you
want to
take
decide.
the wire from the diagonal, you go into the circumflex. You do an IVUS on the circumflex.
All right.
I think I'd be really interested in that FFR.
If you want to do FFR, we can do FFR. I think would be very teaching. I think would be.
All right. Anyway.
It's nice to do predictions, but science is made by
All right,
facts.
Dr. Kao, if FFR is negative, right?
Yeah.
What
If
does it do then?
FFR is negative, you are the boss.
Just leave
How
it
would
if
you
it's
do
negative.
that, Dr. Kao?
Yeah, I think,
Negative FFR.
sorry, go again?
You want to do that?
No, I want to.
At
I
the
think,
beginning is
I think doing an IVUS from LED here is not hurting. You do an IVUS, maybe you will show that the stent ends right distal to the circumflex ostium. And what we are seeing from the angiogram is actually just a hallucination. Then we don't do anything. Right?
Well, but I mean, if you have physiology,
like
then
it.
it's unequivocal that flow is not limited, right? So I think that information
Yeah.
is quite valuable.
All right. There's others.
So from that
Quick
perspective, yeah. And there's pretty good data on bifurcations that if the physiology is negative, the outcomes are good.
So the stent is excellent.
Uh-huh. For high pressure, 18.
I think we have like 14, 15 square millimeter.
Very nice.
You see, amazing. Very good results.
Positioned beautifully, yeah.
With this very large lumen, you don't need the DAPT.
Let's look
All
for
right,
that
we don't
circumflex
need
ostium.
more high pressure.
No, we
information.
don't need
Right,
more
that
high
is why
pressure.
Effective stent
We
is
can
putting
go.
out.
We can go in the circle. You want to do FFR on the circumflex?
I think the landing is perfect.
FFR is-
No need
would
to
be
do
negative.
anything.
I know that.
Why?
FFR.
But
All
show
right.
it. Show.
Okay, we're going to show that.
Do
FFR.
FFR.
right?
Do
Why
FFR.
not? Do
Let's
FFR.
do FFR. It takes 5 minutes.
All right.
SJ, if you could do FFR and then just do an IVUS on it, that'll be fantastic.
Yes, yes.
Then you can see the
We'll-
lumen
we'll
area
show
is
that.
good.
And so,
Then
You know,
but
SJ, SJ, you know what?
Based on the-
One possibility is that you open up the LED so good, and the guide is now shooting into LED, so there is some flow disturbance into the circumflex. So what we are looking at is actually not true. Maybe the lumen is big. There is a mixing. happening.
exactly.
Why you prepare the FFR? Let's do a quick IVUS on the circle.
all right, just.
But we have to place the
all right,
wire.
we're
Let's
gonna
do the FFR first.
You're going to see that. Actually,
we
in
do.
our real practice, I didn't do the FFR. The reason why it would be negative,
Yeah.
based on our data.
But we
is
want to
already-
show to the
All right,
audience.
right. Okay, we're going to say that.
You can remove the wire from the diagonal.
We don't need that one.
You don't need the wire
Yeah.
in the diagonal.
Diagonal wire.
Take
is
the
out.
wire out.
Okay, no problem. Slowly. Test it.
What a great ending for a great meeting, right? This last case is really interesting.
If the FFR is positive, what will you do? The landing is perfect.
You have to dilate.
SJ, Jung-Min Ahn wants to show us his final result, and then we'll come back to you in a minute or two.
Okay.
All right.
All right?
Okay.
All right. Let's go to Dr. Ahn.
Yeah, FFR wire.
Yeah,
Jung-Min,
I
we're
already
back.
completed my. Yes, I already completed my procedure.
Great.
So this is the final angio, So my concern is the circumflex. Could you show us the circumflex IVUS? That circumflex actually is the ramus to the left main. So more than 3.0 big vessel, we implanted the 2.5, but using the 35 high pressure. Can you see the 12 o'clock, the circumflex coming?
Yeah.
Here is left main. Left main is huge. I applied the 4.5. And already we did the final kissing balloon. So this is the final engine. For the proximal portion, some matter position, this is acute matter position. Without stand under expansion, acute matter position doesn't affect the patient long-term outcomes.
Agreed.
So definitely we need 5.5 or 6.0 to oppose the stand. So I leave it alone. I will leave it alone. Could you show us the? This is IP cranial view, and next previous one. No, spider. Final spider view. Okay, I like to show you the final view, and then finish my procedure. So even though very complex left main trifurcation, yes, the two stenting is also complex, but sometimes upfront two stent is the most simplest way to treat the complex left main treatment.
I think that looks fantastic.
LAD and circumflex is huge and huge.
Can you show us an
without
AP
any
caudal,
hemodynamic?
AP caudal shot? We can see the circ.
Yes, without any hemodynamic compromise, we finish the procedure. Ready?
Very nice. Beautiful.
Yeah. Wonderful.
Thank you.
Thank you. Wonderful.
Congratulations. Can we go back to SJ? Yeah.
7. Can you flush the water?
Okay, adenosine.
Yeah. You already did.
된 거죠? 네. Don't touch.
Yep.
Alright. We gotta do adenosine infusion for that.
So PDPA is 1.
1, yeah.
That's a very good sign.
So
So
SJ
you
is
don't
always
need
right.
to do adenosine.
Oh, no, we need adenosine.
You did? But if PDPA is 1.
For the data.
Yeah, we can do adenosine, but it's almost impossible.
주는 거야, 지금?
네, 굉장히
Everyone in the audience is still here with their breath held.
Yeah, but it's going to be 0.92.
Okay, still the pressure has to just drop down a little bit.
He got adenosine already? Not even 92.
Adenosine too? 200? All right. Getting decreased pressure over there, however, nothing changes. A little bit further. You want to wait for. 이거 뭐, it's not a technical error. It's okay.
아 이제 떨어지나? 아 이제
FFR이 이렇게 안 떨어질 수가 있어?
아니요. 지금 혈압이 라인 괜찮아요?
네.
지금 떨어지는 거.
No. So pretty negative, right?
지금 들어간 거 아니야?
Very good. All right. All right.
Yeah.
Nothing changes.
Not even the pleasure to see 95, 96.
95. Right.
주사제는 괜찮아?
I like to see IVUS.
IVUS?
Yeah.
All right, why not?
Let's see IVUS.
The pull back. 뒤로
너무 안
안 내려오시는
떨어져,
fusions.
We can use this wire to do the IVUS.
저건 네가티브.
알겠어.
그냥 이 와이어로 그냥 하면 안 돼? 그 와이어로 폴백하고 파이널이 나. Okay, no, absolute no change at all.
Yeah.
거기다 그냥.
Well, you got 0.97,
I was
right?
for one.
So that's pretty good.
Yeah.
알겠어. 그 와이어로. 알아.
But if you don't do FFR and you show this angiogram to 100 interventionists, I think the majority will tell you that the stenosis is critical.
But that's the beauty of physiology.
Yeah. But we don't know what is the long-term outcome of this kind of discrepancy. We like to see these cases after 2 or 3 years.
We have some, it's
You
a
have
small
some,
data about that.
I think that would be a very important study, paper, retrospective.
Not too much, all right? Good, perfect. Okay, you want to see that?
So
What's
the
happened?
vessel is huge.
Huh?
The vessel is 1, 2, 3, 4, 5 millimeters.
Big vessel.
Moment of.
We are
Fine,
expecting
there is
to
some
see an
calcium,
oval-shaped lumen.
Reverberation.
Yeah, there you go. It's sort of oval-shaped.
lumen
So
is good.
the lumen is very eccentric.
But the area should be okay.
Eccentric, however,
And the stand is spot on.
Yeah, there you go.
There's no impingement into the
Open,
second.
wide open.
What is the area? Just to
And we get what
area.
we call optical distortion because there is such a mismatch between the ostium and the vessel distally that our eyes gets distorted and they perceive what is small too small. It's already better. It's a little bit better.
If the guy is more into the left main.
Yeah.
I
This
think,
is such an educational
I think
case.
AJ
It
was
tells
a
you.
good idea not to dilate. I think it was a good idea.
This is really a good teaching case.
I think it's very important.
Tester. All right, take a
yeah.
picture here and again. The first
Yeah,
one.
this
Beautiful,
picture is
Yeah.
very good. Excellent case.
All right. You do. Tell you everything. Anyway, all right, we're gonna show the last spot of your game. There will be some.
우리 이 뒤에서
Alright.
내년에 그거 가지고 이렇게 왔어.
Okay.
Yeah.
I think
Very
it's
nice.
quite enough.
I
right?
think it's okay.
Yes.
All right.
But it's a very, not even 95, 96, huh? One.
Very
All right.
educational. Thank you.
Thank you.
Thank you. And
All right. Anyway, I would say,
Yes.
all right, this is the last cases, and I really, today's cases, most of our live demonstration cases would be left the main.
Yeah,
right?
yeah.
You know that.
Oh.
Very much complex one.
Why people in Korea always get left
I'm
me?
telling you, the basic assumption our course, our live demonstration, main disease is not a surgical disease anymore, right? We don't do talking about the surgery for any complex,
I
the
don't
main
think you
disease
should
substance.
carry 2.5 balloons in the car.
Right. So, all right. The meaning is maybe from the next years we want to some changes our meeting characteristics, including the complex angioplasty, and mainly focus on the main intervention further. Right.
Yeah.
Anyway, during the last 30 years, 40 years, we've changed a lot. It's a guideline concern. However, practical issue, still we have a lot of problems and lots of talking to discuss, and so
Good.
maybe Antonio will
Thank you.
help us more friendly. Right?
Thank you,
Thank you
thank
for
you.
that. All right, see you.
Yes,
So,
thank you, thank you.
All right.
And we sincerely appreciate Antonio Colombo is participating the wonderful last live
I
case.
think it's a privilege
Yeah.
and really to work with SJ,
Yeah.
listening to his
Yes,
comments,
yeah.
and especially about the
Yeah,
of the circumflex.
Absolutely.
I think was very
Yeah.
teaching because
I think it's most of the audience really enjoys the combination of Antonio Colombo, S.J. Park. And thank you, everyone. And next year, we will prepare the much wonderful and complex case. And really appreciate joining this year complex PCI meeting.
Yeah.
Thank
All
you.
right.
Thank you.
Title, the main summit. Something.
Yes. Thank you.
Thank you.
See you
All
next
right.
year.
Great.
thank you.
Thank you. See you
아이고,
next
네네.
year.
우리 여기서